Um, these are my disclosures. None of these are current, but they all participate in this space. Before I talk about diagnosis and get into the topic for today, I did want to reflect a little bit on how we're at an inflection point, I think, in the care of C. difficile. And I'm reflecting on this as someone who's been thinking about this disease for the last 20 years. When I was an intern, I remember how our diagnostic tests were pretty terrible. Some of you who were in practice in the mid 2000s remember this too, that we often had to send 3 tests before we even could call someone as negative for C. difficile. We had these enzyme immunoassays that were just very poorly sensitive. And now we've come full circle where we have these exquisitely sensitive PCRs and we're worried about picking up asymptomatic colonization too much. The epidemiology has changed quite a bit too. That was an era where we had the epidemic strains that were circulating. They spread worldwide, causing a lot of severe disease. We're not luckily seeing as much of that severe disease in the inpatient setting as we did back then. But now we have this problem of recurrence, which you're hearing about today and you'll hear more about as talks go along. So I think it's just kind of an interesting time in C. difficile where we have a wealth of diagnostic tools available to us, and we have to grapple with that problem instead. So with that, I just wanted to also say that this talk is not for administrators, infection preventionists, public health epidemiologists, or healthcare economists specifically. Again, not to say that these folks don't have very important, if not crucial, roles in managing C. difficile in our patients, but I trained as a physician. That's my core identity. And so for this talk, I wanted to bring it back to the patients and focus on how we diagnose C. difficile and thinking about it from that perspective. Not to say that there aren't important things to consider from other broader perspectives. But I only have 15 minutes. So, and then the diagnosis in the current state of the field is where I wanted to start. But before we get to that, let me just review the biology. Again, not to go through this in depth, but I think there are some points here I wanted to make sure that we are all in agreement about and know when we think about diagnosis, because it helps me think about diagnosis when I approach patients. So one is that this is a gram-positive anaerobic spore-forming bacillus, and that spore-forming aspect of the biology has implications for diagnosis. This spreads, it's in the environment, it's in a lot of patients asymptomatically. And the syndrome, as we know, can be an asymptomatic colonization state, but many people can have an acute illness, sometimes self-limited. Sometimes it progresses to a more severe case that can cause severe disease or even fatality. And this is a big burden. Again, I'm not going to review this in too much detail, but we still see hundreds of thousands of cases a year in the United States alone. And a lot of this is driven by recurrence, which is a big problem. And we have to think about the diagnosis both on the front end and on the back end. And finally, just to kind of review in detail some of the pathophysiology, again, with the idea of diagnosis here. C. diff is unusual in that in many other microbes, you can get the infection if you have a susceptible immune system and you're exposed. But here, actually, many immunocompromised patients don't get C. difficile until something else happens to them. That something else is often exposure to antibiotics, which deplete those healthy bacteria, providing colonization resistance in our gut. And when those bacteria are depleted, that can then be a susceptible period during which, if you're exposed to spores, they can germinate and produce toxin and cause disease. However, there's a lot of exposure to spores that happens. It's not just in healthcare settings, as we'll learn. There are people who are walking around with both vegetative C. difficile and spores completely asymptomatically. And as we'll see, there's actually people walking around with toxin levels detectable in their stools who are completely asymptomatic. So all of this is making the diagnosis of C. difficile in 2025 pretty challenging. I alluded to this briefly. One of our earlier speakers, Dr. Gary, was on at least one of these studies that I'm citing here, where we think about this as a healthcare associated illness and that it's present in healthcare settings. But really, C. diff is essentially ubiquitous in our environment. Maybe that's a little bit of an exaggeration, but we see it essentially everywhere we looked. And it's in park benches and people's homes and chain stores and fast food chains. But we also see it in grocery stores and in the produce that people are buying. Now, the point of this slide is not to implicate potatoes or root vegetables in particular, but just to say that this is something that we're exposed to a lot in our daily lives, even if you're not in a healthcare setting. And I think that informs kind of who we should test. And the recommendations and the guidelines is that we should not be testing asymptomatic patients. And the reason is because there is this colonization state, or at least a transient carriage state that we think exists. Treatment doesn't decrease the risk of C. diff in that patient. It doesn't decrease the risk of spread. having this long-term colonization might actually be protective. I'm not citing individual studies about this, but Natasha Bagdasarian and I wrote a review in JAMA back in 2015 that does cite a lot of these studies. On this next slide, I do bring up some of the individual data on this, but to explore colonization a little bit more, this is very common in hospitalized patients and patients in long-term care facilities, but even healthy adults walking around outside, you'll find it in a small fraction of them. The one population I wanted to call out in particular is infants. Under a year of age, more than half of infants are colonized asymptomatically with toxigenic C. difficile. And it's the same strains causing disease in their grandparents and adults that we see in the hospitals. We don't really know why they're asymptomatically colonized. They don't have any symptoms from this, but it is a very common phenomenon. And so again, to pull on the point I was making in the previous slide, you might think surely eradicating this carriage is beneficial. We would want to do that, right? It would prevent C. diff in that person and prevent them from spreading it to another person. But it turns out that it might backfire. So these are mouse data here on the right, where the red line and the blue line are showing blooms of vancomycin, or blooms of C. difficile in patients. But these are the patients that actually got vancomycin. And in fact, the blue line, which has much higher blooms for longer periods of times, are the mice that got longer courses of vancomycin. This isn't just mouse data. There's data in patients. I cite a study here going back to the 90s that Stu Johnson did, suggesting that humans also, after getting disease, being successfully treated, cured, and not having any symptoms and not getting recurrence, can continue to shed. And as I mentioned, there are some studies also dating back pretty far that some of these patients who have long-term colonization that's stable are actually protected against C. diff and are not at increased risk of getting it. Wanted to pull apart colonization just a little bit more before we go back to the diagnostic topic. This is a study that I did in collaboration with Vince Young, and Mary Hayden really led this and her team over at Rush University in Chicago, where they had this amazing turn team that went into their medical intensive care unit every single day and just looked for C. difficile in rectal swab samples or stool samples from all the patients. Only about fewer than 10 patients, I think, from the study, I don't have the number on here actually, but got actual symptomatic C. diff. But about close to 80 out of these nearly 500 patients were detected as having C. difficile at some point asymptomatically during this ICU stay. But this isn't really the whole story because it's not binary. This slide, I think, illustrates why I think this is really an important concept to drive home. So let me orient you to the slide to the graph on the right. Every vertical tracing is an individual day in the ICU after admission. Each horizontal tracing is an individual patient. And where you see a red circle, we detected C. difficile, or Mary's team detected C. difficile on that day. Black circle, it wasn't present. Gray, we didn't get a sample for that day. And pretty much any pattern you can think of, you can see here. There are some people who come in positive and stay positive. Some people who come in negative, pick it up and stay positive. Some people are positive, then negative, and then positive, where they're transiently picking it up and carrying it or passing it. So I think the point I'm making here is that even some of the studies that I quoted about how prevalent C. difficile colonization is in these populations are probably underestimating things. They're only picking it up at the very beginning or at the very end. Very few people are sampling sampling for C. difficile daily like this. So even more important to really test this in the right population. All right, so with that, we made the decision. We have a patient in front of us that we think we should test for C. difficile. Well, who is that patient? Who should be tested? The cardinal feature is diarrhea, and this is the definition that's in all the guidelines, greater than or equal to 3 loose bowel movements in 24 hours with no alternate explanation. That part is key. Those of you who think about C. difficile at the healthcare system level and have maybe participated in infection prevention meetings and guidelines, know that there's a lot of inappropriate testing that happens in patients who just got started on a laxative, just got a tube feed initiated, just got oral contrast for a CT scan. Diarrhea is not unusual or maybe even expected for a little bit of time in some of those patients, but we often see testing happen inappropriately in that setting. So that's a challenge for kind of the systems level. There are patients who don't have diarrhea that have C. difficile, but essentially this is only in patients who have very severe courses. They're already on their way to, they already have an ileus, or on their way to having colitis or even megacolon. So really you're looking at patients who have symptomatic diarrhea. I will also point out that there are patients who, after being treated successfully, can continue to have a little bit of diarrhea. most of those patients, if you probe, it's nothing like the initial episode. It's maybe a few loose bowel movements. Often there's upper tract symptoms too, like bloating, and they may fall into this post-infectious IBS situation where also treatment and testing is not necessarily beneficial against C. difficile. All right, so you have a patient in front of you. You're pretty sure that they meet the case definition, and you want to test to see if there's toxigenic C. difficile there. That's really the goal. Is all of this testing is now to help you figure out, is there toxigenic C. difficile present in that person's stool? Two basically broad ways to do that is to look for the gene using these nucleic acid amplification tests. That's nice because in one step, it tells you that it's not just C. difficile, but toxigenic C. difficile. Here, it's worth reminding ourselves that there are non-toxigenic strains of C. difficile. They don't cause human disease, so we don't identify those for clinical practices. And then the other strategy is not to look for nucleic acids or the genes, but to actually look for their products. And we often will look for toxins, the proteins themselves, as well as this protein, this enzyme, glutamate dehydrogenase. Glutamate dehydrogenase is made ubiquitously in high levels by all C. difficile, so it's a very analytically sensitive target. However, non-toxigenic C. difficile makes this too, so you can't just hang your hat on this test alone. You have to pair it with a toxin assay. However, the toxin assays, as I mentioned, they're a little bit better than back when I was an intern, but they're still fairly low analytic sensitivity. And the clinical specificity varies. The reason I say clinical specificity varies is because none of these tests will tell you if the patient's symptomatically colonized or asymptomatically colonized or symptomatically infected. You have to bring it back to the patient. And you might look at this and say, well, these have higher clinical specificity. Surely if we just had a really good toxin assay, then we would get better at the clinical specificity. I'll get back to that in a point. I just felt obligated to show some of the sensitivity and specificity data from the laboratory analytic perspective. This is not the only one, but one of the better reviews done by Colleen Kraft a few years ago on looking at all the tests that are out there. And the punchline is you have pretty good specificity and sensitivity when you're looking at nucleic acid testing, GDH and NAT testing, or some other more complicated algorithm. However, what's the gold standard here? It's not the patient who has symptoms. The gold standard here is another test, and it's often these culture assays or cytotoxicity assays, which, by the way, none of our labs even do clinically anymore. So really what we're seeing emerging at a systems level is lots of different methods to try and increase that clinical specificity when you do get a positive test. And we're seeing labs rejecting form specimens in their microlab policies. We're seeing testing algorithms being implemented in various ways. Some people have EMR alerts that pop up. So if a patient is on a laxative or did just get oral contrast for a tube feed or tube feeds, the alert might pop up and say, hey, are you sure you want to check C. diff in this patient? And at our hospital and other places have seen that actually reduce inappropriate testing. Some places have gone pretty draconian with their filters, where they actually have stewardship personnel review every single case to make sure that it's an appropriate test before it even gets sent. So going back to this idea of, well, maybe it's just we don't have appropriate enough testing. Surely if we detect toxigenic C. difficile and detect actual toxin in a patient at a sensitive level, that's got to be clinically specific, right? Well, unfortunately, it doesn't seem to be the case. So this is a study done years ago now, where on the left, you have PCR positive patients who had symptoms. On the right, these are PCR positive patients, but they're completely asymptomatic. They're carriers. And the thing that I found very distressing from this study is both for toxin A on the top and toxin B on the bottom, there are completely asymptomatic people with shockingly high levels of toxin walking around. And so this doesn't save you. You still have to go back to the patient, and you must integrate the test results with the clinical presentation. I will throw in a buyer beware when it comes to the BioFire or any of these multiplex panels. These are increasingly used, and especially in our GI colleagues, because often they have many other things in their differential when they're thinking about C. difficile in their patients. And so this is attractive in the sense that even though it's an expensive test, it tests for a lot of things, including C. diff. The problem is there's no ability to reject form specimens with most of these assays. That they're collected in media. So even if they're solid stool, it's homogenized by the time it makes its way down to the micro lab. They include TCDA as a target. It's not a strong weakness, but there's a reason why most commercial PCRs only focus on TCDB. Many of us don't really think there's that many strains, if any, that are TCDA positive and B negative that have clinical relevance. This is more theoretical, but there is a purification step after this extraction. So for many reasons, the standalone PCR tests that that do these multiplex assays may actually decrease your clinical specificity if they're not used in the right population. So the CDC knows this, and the CDC knows people have been starting to game the system to try and report something one way to clinicians and another way to the CDC, depending on what order the testing happened in from the multiplex testing panels. And so they're saying, you know what? If you have a test that says that the patient has toxigenic C. difficile, that's great. You have to treat them, and that's what counts as a case. So this is a proposal. The links are there if you want to go read through the slide deck and look through this in more detail. But I think it's probably going to be adopted. And I think this is actually exciting for me because it aligns patient interests, provider interests with sort of the system and public health interests in a way that is concordant. So in summary, I think patients can be asymptomatically colonized. This should not be treated with antibiotics for the reasons that we walked through. Diagnostic tools, they exhibit a trade-off between analytic sensitivity and clinical specificity. And then one really has to integrate the test results with the patient presentation to arrive at a correct diagnosis. There's no very clever test that's going to save us from that. So with that, those are all the slides I have. And I'm not sure if I have time for questions, but I'm happy to take any if there are.
Hey, Krishna, thank you so much for that. I don't think we have a ton of questions. We did have somebody ask, how would you know a test is being done, and can you get a false negative? I think this is a common thing, especially when people have had C. diff. They're concerned that they have it and it's not showing up.
Yeah, so I think false negatives can happen. They're way less likely with the nucleic acid-based tests just because they're exquisitely sensitive. I worry about that more with the toxin-based assays that look for the protein products using EIA or ELISAs. Those have a much higher false negative rate. And the place where we see those show up now is in multi-step testing protocols. I don't know of any centers that are only using toxin assays to diagnose C. diff. If they are using toxin assays, it's usually part of a multi-step panel where there's a PCR and then often a reflex to toxin. And in those situations, some of those PCR positive, toxin negative patients do have real disease that need to be treated. So you still have to use your clinical judgment there.
Yeah, and then Brenda asked, could it be helpful to know if you're colonized prior to getting high-risk antibiotics, like for a UTI?
Yeah, I'm not sure if anyone's done studies looking at the colonization status specifically with that. Certainly, the antibiotic that you get makes a big difference in terms of your risk of getting C. difficile subsequent to that. Some of the antibiotics used to treat UTIs, such as the beta-lactams, especially with the beta-lactamase inhibitors, which aren't commonly used for UTIs, but many other infections, those are high risk. Other ones that we might use, like Bactrim or tetracyclines, are much lower risk. That's true, I think, regardless of whether colonization is there or not. So if you're the kind of patient that has elevated risk for C. difficile, absolutely, if you need an antibiotic for any reason, that should be factored into the decision-making process in terms of which antibiotic you choose.
Yeah. So Susan O'Brien asked, and it's funny. So we're developing a document that will probably come out early in the new year about how to talk to your doctors about antibiotics if you've had C. diff, because this comes up a ton. But from your perspective as a physician, Susan's asking, what is the best wording for patients to use when they're requesting a test? Like if they have one that they think is better, or is that something that, depending on where you are, the doctor's not going to have much control over?
Yeah. Well, I mean, I guess there's an unstated premise there that, patients should be thinking about and requesting tests separately without discussing it with their doctors, right? So I would just push back on that and just say that I think a patient should bring up their concerns to their doctors. If they're worried about C. diff, they should bring up that concern to their doctors, be transparent about the symptoms they're experiencing, and then have a shared dialogue and discussion about the appropriateness of testing, right? The doctor might look at that and say, hey, I think I am worried about this being a recurrence, even though we recently just had it. Or yeah, your symptoms are kind of borderline, maybe we should test and see. Sometimes there can be a lot of fuzziness there. So I think just be open and honest about your symptoms and what your concerns are with your physician.
All right, I think we have one more. We have it. We have a frequent question, which is how do you test to make sure that you're clear of C. diff? And the answer is you cannot. That doesn't
Yeah, as we
exist.
mentioned, even after a successful cure and you take a cohort of patients who will never get C. diff again, there's a fraction of them that will continue to just test positive. Some of them do turn out to be long-term carriers. And the actual frequency of that happening and stuff, we don't have great estimates on. But yeah, I think a test of cure is not something we recommend in almost any situation. It's going back to the symptoms and are you still experiencing symptoms? And then that should drive the testing decisions. Yeah.
Yeah, and then Travis, who's one of our top questioners today, asks, what do you think about combining combining host and pathogen components for a diagnostic test, toxin EIA plus cytotones, etc.?
Yeah, so I spent a lot of time thinking about cytokines as biomarkers to help us think about the severity of C. diff and whether they recur. I haven't really seen much signal that's useful that can be translated into patient care yet, combining cytokines with the test result. The idea there is that if you have a positive test result, but let's say your IL-6 is completely normal, you probably don't have C. diff, right? So I think it's an interesting idea. There's probably something there, but I'm not aware of anyone who's really explored that in the research realm, and certainly no one that's using that clinically. But people have looked at things like calprotectin to see if their inflammation in the stool, as measured by that particular analyte, is associated with C. diff, and it doesn't seem to be associated with diagnosis itself, but there is some signal with severity. So I think that's an open question. But yes, so far, still nothing like that has helped us, increase that clinical specificity I was talking about.
And then the last question somebody asked, do you ever retest when there's a recurrence of symptoms?
Yeah, so I think if there is a recurrence of symptoms, and I don't think it's this post-infectious IBS, which a lot of people can experience, then I think a test is helpful, because if you have a recurrence of symptoms and it's negative, well, that's pretty useful, especially if you're using a PCR test. As I mentioned, the analytic sensitivity of these tests is really high. So if someone really does have recurrent symptoms that are compatible and they test negative by a PCR assay, that's helpful. That you're probably barking up the wrong tree. That's probably not C. diff.
Yeah. And sadly, we do know people sometimes struggle for weeks or months with, just their body getting back to normal. Yeah. And some people don't ever quite get back. So, so sadly, we have to leave it there because I could talk to you for longer. But we do appreciate you so much, Krishna, for doing this presentation, and look forward to seeing you again soon.
Yeah, thanks so much, and looking forward to the rest of the talks.